First, I would like to know who is doing cardiac imaging. Cardiac CT is doing somebody? Cardiac CT, some are doing this. And who is doing cardiac MRI? Oh, there's one. This is great, thank you. in the former courses, I guess nobody did cardiac MRI. But it's worthwhile to think about it if somebody is interested in doing this. And this is a very special topic, the cardiovascular imaging after resuscitation. Okay, there's some of them are coming in with coffees. I have my coffee here in the edge, drinking a little bit. Yeah. Let's start with the patient. This is a 33-year-old lady after resuscitation. And in the workup, they found a premature coronary artery disease with a vasospastic component. And the clinicians wanted to know, is there scar tissue and late enhancement? And is there any kind of cardiomyopathy? And in this case, we found this enhancement here. It's subendocardial. You find it here in this area, and you find a perfusion defect and hypokinesia at this area. So this is an ischemic area, and in the distribution of the right coronary artery in the posterobasal and posteroseptal area. Additional to that, we found in this patient a small pneumonia. It is very difficult to say if this is the first thing or the other thing. But in this case, we found something what the clinicians didn't know about. The definition of sudden cardiac death or arrest is a sudden failure of heart activity without any apparent non-cardiac cause, resulting in cessation of breathing and the human body showing no signs of circulation. So this is the definition of this disease. The strongest prognostic factor after sudden cardiac death is the extent of hypoxic ischemic brain damage, because most of the patients suffering of a sudden cardiac death, they don't come into the hospital, they die outside. The next group are those who have been resuscitated by people, and then you don't know what's happening with the brain. And in this case down there's a 49-year-old female patient. She had a resuscitation and a progressive brain edema, and you can see that there's a difference between the first day and the third day. And so the prognosis is not very good in that case. So this is the most important prognostic factor, is brain edema. But sudden cardiac death is a very frequent disease. It makes around 20% of all the death worldwide. Very often it is without any history of a pre-existing cardiac disease, and this is why it's very problematic for preventive activities, because you don't know what to do, and most of those patients have no prior diseases. To the cardiac guidelines, an implantation of an ICD is only indicated if the ejection fraction is less than 35%, and this is the only indication for that. They don't have late enhancement in there, and the interesting point is that in MRI we find some things in the peri-infarction zone, and this is the area where normal myocardium is together with scar tissue, and this is usually an area to arise. There's some electric disorders. What's the role of cardiac MRI in sudden cardiac death in patients with a significant coronary artery disease? This is what we can do there, or can show there, if there are other changes in the myocardium. like functional disorders or structural disorders, and we can do this with T1 and T2 mapping, because in some cases you have no late enhancement, no enhancement at all, but you see some structural differences in the myocardium with this T1 and T2 mapping, what we can do there. Another interesting point is that in patients who had infarction, it is 6 to 9 times more frequent to be affected by a sudden cardiac death than in normal patient population. So all those, if you have a scar tissue in that area and around there, that can arise electric problems and rhythmogenic disorders up to sudden cardiac death. Down there you see a 67-year-old male patient after resuscitation, and he had a known ischemic cardiomyopathy and a huge scar at the lateral wall of the left ventricle and dilative cardiomyopathy. So these, at the, especially at the edges of this infarct area, there can arise some of those electric problems. In patients suffering of sudden cardiac death and coming into the clinic, it makes sense to do imaging, and it's very important to do acute CT exams like brain CT, chest CT, coronary angiography, echocardiography, and in those cases they find a diagnosis which change the therapy in around 42% in this study, and relevant coronary artery disease could be detected in this study in 61%, and in 20% it was stroke and pulmonary embolism, what they found there. And in all those patients without any relevant coronary artery disease or LV dysfunction or rhythmogenic disorders, it's necessary to do a workup of those patients and to find out if there's something within the myocardium. And in this study by Herman, they found in around 41% relevant diagnosis at around 35% structural cardiac disease and 65% with primary electric disorders. So this is, it's very important that the clinicians are doing a workup of those cardiac death patients with several different imaging modalities, especially using MRI. There we have a 54-year-old female patient with a known Church-Strauss syndrome, and she had a sudden cardiac death and resuscitation, and the clinicians wanted to know if there's a cardiac involvement of this primary disease. And the only thing what we found in this case is this unspecific fibrous band, which can be found in several diseases within the septum, and it can be responsible for electric disorders and arrhythmia, but it's not clear if it's really the case. In this meta-analysis, this is quite interesting, by Petek, he analyzed almost 6,000 studies in patients with sudden cardiac death, and in only 0.3% of these cases, non-invasive imaging was mentioned. This is quite interesting. And here in 8 to 54% of the cases, the cause for sudden cardiac death was detected. So in brain edema or brain problems, chest problems, abdominal causes. So it makes sense doing imaging workup in patients with sudden cardiac death. This is our own study done by Dr. Scharinger. It's under revision in radiology and cardiothoracic imaging, and we collected the 13 studies which used MRI and CT with around 1,200 patients. The most of them are male patients, and we found 31% ischemic cardiomyopathy and 25% non-ischemic cardiomyopathies. So in more than 50% we found something what the clinicians didn't know about. And late enhancement is one of the most important findings. It was in 66% the case, and myocardial edema was only there in 70%. This is because these patients don't come immediately after resuscitation to MRI. They usually come within a week or within 10 days when they are in the hospital. 50% of the patients got a new or alternative diagnosis, and it influenced the choice of treatment. So MRI is really worthwhile doing this in those patients because many clinicians don't know about the causes of the sudden cardiac death. In this study from Nilan, they examined sudden cardiac death patients with MRI with unclear diagnosis, and it's almost the same. But we have found that in 71% they had late enhancement, and it was caused by infarction, non-ischemic pattern, myocarditis, or hypertrophic cardiomyopathy, sarcoidosis, and ARVC, that means arrhythmogenic right ventricular cardiomyopathy. This is a disease which is located usually in the right ventricle or outflow tract, and this can cause sudden cardiac death. Here we have this patient again with this huge scar tissue around there, and he got an ICT. We are doing MR imaging with implanted pacemakers and ICTs, and it's working. You can do this if you have a very good connection to cardiology and reprogram the devices. In this study by Rodriguez, he examined 164 patients with sudden cardiac death, and in around 50% they found a diagnosis with cardiac MRI, which influenced the therapy in around 30%, and it was dilative cardiomyopathy, myocarditis, sarcoidosis, and so on. And even in these cases, he had this arrhythmogenic right ventricular cardiomyopathy. So this is quite makes sense doing that. And the interesting point is in those patients who survived the sudden cardiac death, it was very often associated with a major adverse cardiac event in the follow-up of those patients. So they usually can get another event when they survive that. And this is depending, and this is associated with findings what you can find out with the cardiac MRI, like late enhancement or ejection fraction of the right and left ventricle. In this patient down there, this is a 56-year-old male patient after resuscitation with no coronary artery disease at the angiography, and so the clinicians wanted to know if there's a myocarditis or structural disorders. In this case, we found another ischemic area in the posterior apex. It's here, and he had elevated T2. That means that this is a fresh infarction there, and it's edema there. And additional to that, we found in this patient this tumor in the upper abdomen, combined with some liver lesions in there. So we suppose that it is maybe a gastrointestinal stroma tumor or something like that. In this 73-year-old male patient with a history of alcohol abuse and after cardiopulmonary resuscitation, they found nothing in coronary angiography, and the clinicians wanted to know if there's some structural disorder. In this case, we found this dilative cardiomyopathy and an unspecific fibrous band in the septum. Actually, dilative cardiomyopathy can be caused by alcohol abuse because it's a toxic cardiomyopathy. And when you find this late enhancement within the septum, it has a worse prognosis in those patients. Usually they die within 5 years if there's done nothing. And this is, in this case, dilative cardiomyopathy can be called a malignant disease because it usually is leading to death. And in this study from Maastricht, the survivors of sudden cardiac death, MRI found in 63% diagnosis, in around 33% coronary artery disease or cardiomyopathies or drug-induced coronary spasm. Even this is sometimes the case. We have such patients even in our patient population, and channelopathies. It means that it's arrhythmogenic disorders. And interestingly, those patients have usually no family history or hereditary disease, and it doesn't usually influence that. But you can nicely see that the ejection fraction is reduced. It is less than 30%. So with or without late enhancement, those patients usually get an implantation of an ICT because of that guidelines. In this case, 50 years old female after resuscitation, echocardiography showed a minimal pericardial effusion, and the clinicians wanted to know if there is a myocarditis. And the only thing what we found there is this minimal pericardial effusion, no late enhancement, no edema because the tube was normal. So we couldn't find more than that, what the clinicians knew about that. In this study down there, they had in 36% non-ischemic cardiomyopathies and in 28% dilative cardiomyopathies, and in 16% the left ventricle was normal and morphologically normal, but in all the cases they found a late enhancement. Even in normal looking late left ventricles, it can happen that you find some late enhancement there. And only in 20% if they found nothing in this study. So it's really makes sense doing cardiac MRI in those patients. The 66-year-old male patient after resuscitation, after ventricular fibrillation, they found no relevant findings in the coronary angiography. Also, this patient had an alcohol abuse in the history, and the echocardiography, a kind of hypertrophic cardiomyopathy, and so the clinicians want to know if there's amyloidosis or myocarditis in there. And the only thing what we found is an unspecific cardiomyopathy, but with late enhancement at the insertion of the right ventricle in the septum. It's here, it's very irregularly configurated, and we call those not very bright late enhancement gray zones. And gray zones are those areas where you have scar tissue and normal myocardium, and there can arise some electric problems at these areas. Together with that finding, we found this split-like lesion there in the anterior wall, and if this is subendocardial going into the myocardium, it's usually a very small ischemic lesion. The interesting point is that late enhancement is a predictor for having sudden cardiac death in the future. And there are several studies telling this about. This is quite an interesting point. In the United States, around 350,000 patients suffer of sudden cardiac death per year. And those who survive and have an ejection fraction less than 35% get an ICT implanted. And this is around 130,000 patients per year, and this is around $3 billion US in costs. The interesting point is in this case study, late enhancement didn't play a role, but it would play a role if they would work up that. And I guess that in these cases, also those patients would receive an ICT. The problem is how to identify those patients having or are endangered to have a sudden cardiac death. And the only thing what the clinicians or the cardiologists are working now at this time is ejection fraction, and they don't use MRI as a tool, or they don't use the gray zones as a tool in their guidelines. But I guess in some years it will change, that the late enhancement will be in their guidelines included, because they are changing it very quickly, the cardiac associations. And the interesting point is that an ICT implantation does not prolong lives. This is quite interesting. It depends on the late enhancement. So this is what I told you before, is that dilative cardiomyopathy combined with late enhancement is a malignant disease. Risk stratification is another point. As you can see on this table, that is responsible for sudden cardiac death is ischemic cardiomyopathies, and the other group are non-ischemic ones, and this makes around 40% of the causes for that. And in many of these cases, late enhancement is one of the most important findings there. And here we have another patient, it's a female patient after resuscitation. They found in the angiography circumflex artery stenosis, the TTP, TCA with the stent implantation, and in echocardiography they found a dilative cardiomyopathy and a reduced ejection fraction, and they want to implant an ICD, and usually those patients get an MRI in our hospital, so they know a little bit more about, because you can do imaging with implanted ICDs, but you can have artifacts there, and it's more complicated, it takes more time, and so it makes sense if you're interested in the microstructure of the myocardium, doing MRI before implanting ICT. In this case, we found an atrial dilatation with an late enhancement within the atrium. It's clearly seen here in the septum and the lateral wall of the right atrium, and even there on the left atrium is there, and a little bit of mitral valve insufficiency, but no late enhancement in the septum. But we found there an elevation of T1 at 3 Tesla, more than around 1300 milliseconds is pathologic, and this can be caused by fibrosis in the microstructure, and it can be that you don't see it with late enhancement, but you see it with this T1 mapping there. In this series of publications between 2013 and 2019 or 2020, the most important conclusion was that late enhancement is a strong predictor for sudden cardiac death. And I guess this is important to know about that we should use those techniques. In this big series of 650 patients with a younger age group, it's less than 40 years old, 43 patients had a mitral valve prolapse. Many people don't know about it, that mitral valve prolapse can produce extrasystoles and complex polymorph ventricular arrhythmia, and this is because in these cases the mitral valve has a traction on the posterior or anterior papillary muscle, and there can arise scar tissue, and when you have scar tissue combined with normal myocardium, it can be a focus for arrhythmogenic problems. And in this case, we have this ventricular ectopia and a right bundle branch block, and we found this mitral valve insufficiency and this mitral valve prolapse. So this is clearly shown there. In another study from Zorzi, This is interesting. These publications are coming from Padua in Italy. They are very interested in working up those problems with mitral valve complications. They found in this patient group 44 patients. From these, around 3%, 3 patients, around 10% had a prolapse with late enhancement. They had other causes too, but it's almost 10% of these patients have a problem with the mitral valve. And you see in this patient from our series that there's a mitral valve prolapse with a mitral valve insufficiency, grade 2 to 3. And you see this scar tissue in the posterior wall, and even there in the papillary muscle, you can see that in the late enhancement. And so this is the cause why those patients have their arrhythmogenic problems and can suffer from sudden cardiac death too. In this series, they had another patient group which is quite interesting, Takotsubo. This is a stress cardiomyopathy, and even this can lead to a sudden cardiac death. This was a patient, 72 years old, female. This is a classic age for that disease, and she had a resuscitation, and they found in echo this apical ballooning, which is classic finding in Takotsubo cardiomyopathy. And at the coronary angiography, they had no finding, and so they wanted to know if there's something else there. And we found this apical ballooning in the contraction pattern with a very good contraction at the basal myocardium and areas and segments. And in the T2 map, we found this huge amount of edema in the apical area. And this is classic. Usually you don't find any late enhancement in these patients. And it usually takes 6 weeks, and then they are recovered again and have no problems anymore. Sorry. Yeah. Can I check again? Yeah, this is quite another interesting case. In some patients suffering from hypertrophic cardiomyopathy, it can occur that you get an aneurysm in the apex. And these patients usually have late enhancement at the edges of this aneurysm, and they develop arrhythmogenic problems, ventricular extrasystoles and so on under exercise. And this was an athlete, a very young one. And he had this aneurysm, so he had to stop doing sports anymore, and he got an ICT because of that. And in this patient group, and this is quite interesting to know about that, is athletes have a 10 times higher risk to suffer from sudden cardiac death. And the relation between males and females is 10 to 1. This may be because there are many more males doing sports than females. And the interesting point is that in younger patients, channelopathy, that means arrhythmogenic disorders and cardiomyopathies are responsible for the sudden cardiac death. And in the older patients, older than 35 years of age, cardiovascular causes are the main causes for these problems. The idea in athletes is to examine them in advance so that they know if there are some risks of suffering cardiac death during exercise, but it is very difficult to do that. And I will show you this in a minute on the next slide, what's the problem with that. There we have another patient, an athlete after resuscitation and ventricular fibrillation, had no coronary artery disease but a septal hypertrophy and some spots of late enhancement within the septum. And you see this thickened myocardium here in the basal segments. This is the cause why those patients get these arrhythmogenic problems. The European Society of Cardiology recommends in athletes anamnesis, physical examination, ECG, to find out those patients having problems. And if they have positive results, you do an echo, an ECG, stress tests, and even in some cases cardiac MRI. But what should you do with those patients where you find something and they have almost no clinical signs, no problems? Should you stop doing exercise? This is the problem. On the other hand, all kinds of screening can affect the patients and the athletes too. And this is this complicated decision tree. So you have to examine around 100,000 asymptomatic athletes to find out around 400 patients in which you have to do further work up with imaging like CT or MRI or stress tests. And in these cases, only around 100 are there if they need immediate or follow-up or immediate treatment. So you need a very, very large patient population or healthy people to get out some of them who have problems. In our study, we suggest this decision tree. It's not for athletes, it's for all of them. So when patients have a cardiac arrest coming into the clinic and they survive that, they get usually ECG and echocardiography and laboratory workup. And then it is decided in cases where you have a high incidence of coronary artery disease, they are doing coronary angiography. If it's not that high and it's a younger patient population, they're usually doing CT and cardiac CT. And if there is something wrong in these patients and we have maybe unclear cases, we are doing cardiac MRI, and these are the differential diagnoses, what we find there. In around 60% of the cases we find something. The conclusion for this talk is that ischemic cardiomyopathy is the most common cause of sudden cardiac death. So in that areas where you have scar tissue or these gray zones, the prognosis of sudden cardiac death is determined by the cerebral edema. It depends how good the resuscitation is done by normal people or medical people. And the cardiac MRI is the method of choice in unclear cases of sudden cardiac death because lead enhancement is a very important prognostic tool, and gray zones is in particular the most problematic area. Screening is problematic even in the normal patient population and also in this special patient population or people population, athletes. It's very complicated, and you need a huge amount of people examined that you find something out there. And what you should keep in mind is that mitral valve prolapse is frequently combined with ventricular tachycardia and sudden cardiac death. It can happen. And I guess in the future they will change the guidelines of the different cardiac associations and include together to the ejection fraction the lead enhancement as a tool and an idea for the ICT implementation. Okay, thank you very much for listening to me. And feel free for questions. Have you contacted cardiologists? Yes, okay. So when you have contact to cardiologists, are they discussing with you patients after cardiac death or resuscitation? Almost nobody, because we had the same problem in our hospital maybe 10, 15 years ago, and we have a very good connection to each other. So I go to the intensive care unit every day in the morning. I look at every patient. I'm reporting the chest X-ray, and then we are discussing all the patients, what they have there. And in many cases they ask for a CT or MRI, and usually they get in within 24 to 48 hours. So, and out of that, the collaboration is just much better than before. So the interesting point would be if you're interested in intensive care unit, you go to the cardiac intensive care unit, not only reporting the images in your office, but also going there for discussing patients with them. And they like it, interestingly, and they love it. And they tell me that every week that they have a big profit of this collaboration with us. And we also go to the intensive care unit of the cardiac surgeons and the other intensive care units, because there we have this connection between radiologists and clinicians. And I guess this is maybe an idea that you can do this in your hospital too. And then maybe there can arise a collaboration on cardiac, CT or MRI or what else. Okay.